Cerebrovascular accidents. Introduction. In this study session, we will examine how lack of oxygen can lead to the sudden death of a portion of the brain cells. Stroke. When you have studied this session, you should be able to 1. Identify factors affecting progression or extent of stroke. 2. Describe cerebral blood flow. 3. Explain the mechanism of neuronal injury, ischemic penumbra, neuronal death, ischemic stroke, thrombosis, embolism, and global ischemic or hypotensive stroke. 4. Highlight the role of clinical psychologists in stroke teams. 5. Describe psychological interventions in stroke teams. What is stroke? A stroke is the sudden death of a portion of the brain cells due to a lack of oxygen. A stroke occurs when blood flow to the brain is damaged, resulting in abnormal functions of the brain. It is caused by blockage or rupture of an artery to the brain. A stroke is caused by the interruption of the blood supply to the brain, usually because a blood vessel bursts or is blocked by a clot. This cuts off the supply of oxygen and nutrients, causing damage to the brain tissue. The most common symptom of stroke is sudden weakness or numbness of the face, arm or leg, most often on one side of the body. Other symptoms include confusion, difficulty speaking or understanding speech, difficulty seeing with one or both eyes, difficulty walking, dizziness, loss of balance or coordination, severe headache with no known cause, fainting or unconsciousness. The effect of a stroke depends on which part of the brain is injured and how severely it is affected. A very severe stroke can cause sudden death. The two major mechanisms causing brain damage in stroke are ischemia and hemorrhage. In ischemic stroke, which represents about 80% of all strokes, decreased or absent circulating blood deprives neurons of necessary substrates. The effects of ischemia are fairly rapid because the brain does not store glucose, the chief energy substrate, and is incapable of anaerobic metabolism. Non-traumatic intracerebral hemorrhage represents approximately 10% to 15% of all strokes. Intracerebral hemorrhage originates from deep penetrating vessels and causes injury to brain tissue by disrupting connecting pathways and causing localized pressure injuries. In either case, destructive biochemical substances released from a variety of sources play an important role in tissue destruction. Focal ischemic injury. A thrombus or an embolus can occlude a cerebral artery and cause ischemia in the affected vascular territory. It is often not possible to distinguish between a lesion caused by a thrombus and one caused by an embolus. Thrombosis of a vessel can result in artery-to-artery embolism. Mechanisms of neuronal injury at the cellular level are governed by hypoxia or anoxia from any cause that is reviewed below. At a gross tissue level, the vascular compromises leading to acute stroke is a dynamic process that evolves over time. The progression and the extent of ischemic injury is influenced by many factors. Cerebral blood flow. Normal cerebral blood flow, CBF, is approximately 50 to 60 mL per 100 grams means and varies in different parts of the brain. In response to ischemia, the cerebral autoregulatory mechanism compensates for a reduction in CBF by local vasodilation, opening the collaterals and increasing the extraction of oxygen and glucose from the blood. However, when the CBF is reduced to below 20 mL per 100 grams per minute, an electrical silence ensues and synaptic activity is greatly diminished in an attempt to preserve energy stores. CBF of less than 10 mL per 100 grams per minute results in irreversible neuronal injury. Mechanisms of neuronal injury. Formation of microscopic thrombi responsible for impairment of microcirculation in the cerebral arterioles and capillaries is a complex phenomenon. Formation of a microthrombus is triggered by ischemia induced activation of destructive vasoactive enzymes that are released by endothelium, leukocytes, platelets, and other neuronal cells. Mechanical plunging by leukocytes, eukaryotes, platelet fibrin ensues. At a molecular level, the development of hypoxic ischemic neuronal injury is greatly influenced by overreaction of certain neurotransmitters, primarily glutamate and aspartate. This process, called exototoxicity, is triggered by depletion of cellular energy stores. Glutamate, which is normally stored inside the synaptic terminals, is cleared from the extracellular space by an energy-dependent process. The greatly increased concentration of glutamate and aspartate in the extracellular space in a depleted energy state results in the opening of calcium channels associated with N-methyl D-aspartate NMDA and alpha-amino 3-hydroxyl 5-methyl 4-isoxanol proponate AMPA receptors. Persistent membrane depolarization causes influx of calcium, sodium, and chloride ions and influx of potassium ions. Intracellular calcium is responsible for activation of a series of destructive enzymes such as protease, lipase, and endonuclease that allow release of cytokines and other mediators, resulting in the loss of cellular integrity. Inflammatory response to tissue injury is initiated by the rapid production of many different inflammatory mediators, tumor necrosis factors being one of the key agents. Leukocyte recruitment in the ischemic areas occurs as early as 30 minutes after ischemia and reperfusion. In addition to contributing to mechanical obstruction of microcirculation, the leukocytes also activate vasoactive substances such as oxygen-free radicals, arachidonic acid metabolites, cytokinase, and nitric acid. The cellular effects of these mediators include vasodilation, vasoconstriction, increased permeability, increased platelet aggression, increased leukocyte adherence to the endothelial walls, and immunoregulation. Endothelial cells are one of the 4 cell types to respond to hypoxia. This response occurs at morphological, biochemical, and immunological levels, causing a variety of physiological and pharmacological effects. Morphological: endothelial cells swell and form microvilli at the luminal surface of the cells. This results in a reduction in the luminal patency of the capillary vessels. Mechanical plunging by erythrocytes, leukocytes, and platelets ensues. At a biochemical level, endothelial cells mediate the effects of vasoactive agents such as endothelial peptides, eicosanoids, and smooth muscle relaxants, probable nitric acids. which in part modulates the vascular tone of the microcirculation. Activation of endothelial adhesion molecules promotes leukocyte adherence to the endothelial wall, a key process in the initiation of inflammatory process. Ischemic penumbra. Within an hour of hypoxic ischemic insult, there is a core of infractions surrounded by an oligamic zone called the ischemic penumbra, where autoregulation is ineffective. The critical time period during which the volume of brain tissue is at risk is referred to as windows of opportunity, since the neurological deficit created by ischemia can be partly or completely reversed by reperfusing the ischemic yet viable brain tissue within a critical time period, 2 to 4 hours. IP is characterized by some preservation of energy metabolism because the CBF in this area is 25 to 50% of normal. Cellular integrity and function are preserved in this area of limited ischemia for variable periods of time. The pathophysiology of IP is closely linked to generation of spontaneous wave of depolarization, SWD. SWD can originate from multiple foci, some from the ischemic core and others from ischemic foci within the peri-infract zone, penumbra. Sustained increases of synaptic glutamate and extracellular potassium ions are closely associated with the development of SWD. Glutamate receptor antagonists that block transmembrane calcium flux and prevent intracellular calcium accumulation are known to suppress SWD. Hypoxic or rapid depolarization eventually supervenes just before irreversible neuronal death. The two processes by which injured neurons are known to die are coagulation necrosis and apoptosis. Coagulation necrosis (NC) refers to a process in which individual cells die among living neighbor cells without eliciting an inflammatory response. This type of cell death is attributed to the effect of physical, chemical, or osmotic damage to the plasma membrane. This is in contrast to liquefaction necrosis, which occurs when cells die, leaving behind a space filled by inflammatory response or pulse. In TS, the cell initially swells, then shrinks and undergoes pycnosis, a term used to describe marked nuclear chromatin condensation. This process evolves over 6 to 12 hours. By 24 hours, extensive chromatolysis occurs, resulting in pan-necrosis. Astrocytes swell and fragment, myelin sheaths degenerate, irreversible cellular injury, as demonstrated by eosinophilic cytoplasm and shrunken nuclei, are seen between 8 to 12 hours after arterial occlusion. The morphology of dying cells in coagulation necrosis is different than that of cell death due to apoptosis. The term apoptosis is derived from the study of plant life, wherein deciduous trees share their leaves in the fall. This is also called programmed cell death because the leaves are programmed to die in response to seasonal conditions. Similarly, cerebral neurons are programmed to die under certain conditions, such as ischemia. During apoptosis, nuclear damage occurs first. The integrity of the plasma and the mitochondrial membrane is maintained until late in the process. Ischemia activates latent suicide proteins in the nucleus, which starts an autolytic process resulting in cell death. This autolytic process is mediated by DNA cleavage. Apoptotic mechanism begin within 1 hour after ischemic injury, whereas CN begins about 6 hours after arterial occlusion. This observation has an important bearing on future directions of research. The manner by which apoptosis evolves is a focus of much research because, hypothetically, neuronal death can be prevented by modifying the process of DNA cleavage that seems to be responsible for ischemic stroke are A. Thrombosis, 2. Embolism, and 3. Global ischemia or hypotensive stroke. All ischemic stroke do not neatly fall into these categories, and the list of entities responsible for unusual stroke syndrome is very long. However, strokes caused by vasospasm, migraine following SAH, hypertensive encephalopathy, and some form of arthritis stand out among the more infrequent causes of stroke. Arteriosclerosis is the most common pathological feature of vascular obstruction resulting in thrombic stroke. Arteriosclerotic plaques can undergo pathological changes such as ulcerations, thrombosis, calcifications, and intraplaque hemorrhage. The susceptibility of the plaque to disrupt, fracture, or disrupt ulcerates depends on the structure of the plaque and its composition and consistency. Disruption of endothelium that can occur in the setting of any of these pathological changes initiate a complicated process that activates many destructive vasoactive enzymes. Platelets adhere and aggregate to the vascular wall flow, forming small nidai of platelets and fibrin. Leukocytes that are present on the site within 1 hour of the ictus mediate an inflammatory response. In addition to arteriosclerosis, other pathological conditions that cause thrombic occlusion of a vessel include clot formation due to hypocoagulatable states, fibromuscular dysplasia, arthritis, giant cells, and Takayusu, and dissection of a vessel wall. In contrast to the occultation of large arteriosclerosis vesicles, lacuna infarcts occurs as a result of occlusion of deep penetrating arteries that are 100 to 40 mm in diameter and originate from the cerebral arteries. The putamen and pallidum, followed by pons, thalamus, caudate nucleus, and internal capsules are the most frequently affected sites. The size of a lacuna infarct is only about 20 mm in diameter. The incidence of lacuna infarcts is 10% to 30% of all strokes, depending on race and pre-existing hypertension and diabetes mellitus. The small arteriole, most frequently as a result of chronic hypertension, lengthens, becomes tortuous, and develops subintimal dissections and microaneurysms, rendering the arteriole susceptible to occlusion from microthrombi. Fibrin deposition results in lipohyalinosis is considered to be the underlying pathological mechanism. Embolism. Embolic stroke (ES) can result from embolization of an artery in the central circulation from a variety of sources. Besides clots, fibrin, and pieces of arteriomatous plaque, materials known to embolize into the central circulatory system include fat, air, tumor or metastasis, bacterial clumps, and foreign bodies. Superficial branches of cerebral and cerebellar arteries are the most frequent target of emboli. Most emboli lodge in the middle cerebral artery distribution because 80% of the blood carried by the large neck arteries flow through the middle cerebral arteries. The two most common sources of emboli are the left-sided cardiac chambers and the large arteries, e.g. artery to artery emboli that result from detachment of a thrombus from the internal carotid artery at the site of an ulcerated plaque. The neurological outcome from an ES depends not only on the occluded vascular territory but also on the ability of the embolus to cause vasospasm by acting as a vascular irritant. The vasospasm can occur in the vascular segment where the embolus lodges or can involve the entire atrial tree. Vasospasm tends to occur in younger patients, probably because the vessels are more pliable and less atherosclerotic. Many embolic strokes become hemorrhagic, causing hemorrhagic infarction (HI). Hemorrhagic infarction, used here synonymously with hemorrhagic transformation of an ischemic infarct, is an ischemic infarct in which bleeding develops within the necrotized cerebral tissue. The pathogenesis of hemorrhagic transformation of a pale infarct is a complex phenomenon. The two common explanations that are advanced to explain the pathogenesis of HI in embolic strokes are hemorrhagic transformation occurs because ischemic tissue is often reperfused when the embolus laces spontaneously and blood flow is restored to a previous ischemic area. An initial vascular obstruction is likely to occur at a bifurcation of a major vessel. The occlusion may obstruct one or both of the branches, producing ischemia of the distal tube. Blood vessels as well as brain tissues are rendered fragile and injured. When the occluding embolus either lyses spontaneously or breaks apart and migrates distally, CBF is restored to the injured or ischemic microcirculation. This can result in a hemorrhage or red infarct in what had previously been a bloodless field. This area that continues to be poorly perfused are referred to as pale or anemic infarcts. 2. Hemorrhagic transformation is also known to occur with persistent occlusions of the parent artery proximally, indicating that hemorrhagic transformation is not always associated with migration of embolic material. HI on the periphery of infarct in presence of persistent arterial occlusion is caused by reperfusion from leptomeningeal vessels that provide collateral circulation. In patients with ES, it is not unusual to see HI side by side with infarcts or hemorrhagic infarction include the size of the infarct, richness of collateral circulation, and the use of anticoagulants and interventional therapy with thrombolytic agents. Large cerebral infarctions are associated with a higher incidence of hemorrhagic transformation. Hypertension is not considered to be an independent risk factor for hemorrhagic transformation of an ischemic infarct. Global ischemic or hypotensive stroke. Profound reduction in systemic blood pressure due to any reason is responsible for hypotensive stroke. Some neurons are more susceptible to ischemia than others. These include the pyramidal cell layer of the hippocampus and the Purkinje cell layer of the cerebral cortex. Cerebral gray matter is also particularly vulnerable. Abundance of glutamate in these neurons render them more susceptible to global ischemia. Global ischemia causes the greatest damage to areas between the territories of the major cerebral and cerebellar arteries, known as the boundary zone or watershed area. The parental temporal occipital triangle at the junction of the anterior, middle, and posterior cerebral arteries is more commonly affected. Watershed infractions in this area cause a clinical syndrome consisting of paralysis and sensory loss, predominantly involving the arm. The face is not affected and speech is spared. Watershed infarcts make up approximately 10% of all ischemic strokes, and almost 40% of these occur in patients with carotid stenosis or occlusion. Factors affecting progression or extent of stroke. 1. Rate of onset and duration. The brain better tolerates an ischemic event of short duration or one with low onset. Collateral circulation. The impact of ischemic injury is greatly influenced by the state of collateral circulation in the affected area of the brain. A good collateral circulation is associated with a better outcome. 3. Health of systemic circulation. Constant cerebral perfusion pressure depends on adequate systemic blood pressure. Systemic hypotension from any reason can result in global cerebral ischemia. 4. Hematological factors. A hypercoagulable state increases the progression and extent of microscopic thrombi, exacerbating vascular occlusion. 5. Temperature. Elevated body temperature is associated with greater cerebral ischemic injury. And 6. Glucose metabolism. Hyperglycemia can adversely influence the size of an infarct. Role of clinical psychologists in stroke teams. 1. Direct patient contact. This includes assessment, formulation, and management of psychological disorders post-stroke, including depression, anxiety, self-esteem issues, and adjustment difficulties. It is also necessary to do an assessment, formulation, management, and cognitive rehabilitation of post-stroke impairment, as well as assessment and management of behavioral problems post-stroke. 2. Indirect patient contact. This includes an assessment of career strain on patients post-stroke, working with career as a co-therapist, consultation and advice to therapists/external care providers. And 3. Teaching/training and research. Psychological interventions. Often, cognitive behavioral therapy (CBT) is advised because CBT is collaborative, that is, based on sharing information of problems, goal-driven, problem-focused, that is, what strategies can be put in place to alter maintaining factors. CBT is also relatively brief. Focus of psychological therapy for mood disorders after stroke. 1. Behavioral components. Example, anxiety management, graded exposure, behavioral activation, etc. And 2. Cognitive components, e.g., normalization, challenging negative thoughts, cognitive restructuring, etc. Study session summary. In this study session, we discussed how portions of the brain may suddenly die due to lack of oxygen. The two major mechanisms discussed include ischemia and hemorrhage. Our discussion covered the following: factors affecting the extent of stroke, the normal cerebral blood flow per minute and varies in different parts of the brain, concerning thrombi responsible for impairment of microcirculation in the cerebral arterioles and capillaries. The two processes by which injured neurons are known to die are coagulation necrosis and apoptosis, and global ischemia or hypotension. Arteriosclerosis is the most common pathological feature of vascular obstruction resulting in thrombotic stroke. Embolic stroke (ES) can result from embolization of an artery in the central circulation from a variety of sources. Besides clots, fibrin, and pieces of atraumateus plaque. Materials known to embolize into the central circulation include fat, air, tumor or metastasis, bacteria, clumps, and foreign bodies. The role of clinical psychologists in stroke teams include direct patient contact, indirect patient contact, as well as teaching/training and research. Often, cognitive behavioral therapy (CBT) is advised because CBT is collaborative, that is, based on shared information of problems, goal-driven, problem-focused, that is, what strategies can be put in place to alter maintaining factors. CBT is also relatively brief. End of study session 11. Thanks for listening.